pediatric level 2 trauma centers in Georgia, and you see where those are placed on the map. Based on information provided to the State Office of EMS and Trauma, there are 728 available pediatric trauma beds in Georgia. That's statewide. 64 of those beds are intensive care level. Georgia's 2005 population shows that 24% of that population is less than 15 years of age. In response to the questions that you submitted for recommendations, first and foremost, as an essential element for Georgia, is the communication system. Some of our previous presenters have already alluded to that. That communication center needs to be fully integrated, needs to provide 911 or enhanced 911 statewide, and there needs to be prioritized dispatching for trauma patients. A second essential element would be pre-hospital care, and this would result in getting the right patient to the right place in the right time, hopefully for a child within that planned 30 minutes. In a manner to address that in an expeditious way, there needs to be standardized trauma triage criteria where the field or first responders know that if this criteria is met, I do not go to the closest facility, I do not go to a level 3 or a level 2 center that does not have neurosurgical coverage, but I bypass those centers to go to the most appropriate level of trauma care unless, of course, immediate airway or hypotensive stabilization is needed. There also needs to be standards for transport protocol where that patient is gotten to that appropriate trauma center by the most expeditious manner, be that ground, air, or fixed wing, rotary or fixed wing transportation. Many times our patients are come to us by ground transport when air would have been the most appropriate. By the same token, we have many patients flown to us that could or should have come by ground transport. A third essential element for trauma system in Georgia is injury prevention. As Dr. Gage already alluded to, you prevent it to start with and you don't have to deal with it on the back end. We need to look at what sort of injury prevention programs are needed, implement interventions that address those types of injury, and then evaluate those interventions to see that the prevention interventions have been the most expeditious manner. Just to give you an idea of what is happening to children in Georgia when they sustain traumatic injuries, this is data for 2004 and 2005 for Eggleston and Scottish Rite. 66% of our patients come to us from St. Elsewhere. We do not get them directly from the scene of the accident. They go to the closest facility, be it a trauma center or not, and then are transported on to Eggleston or Scottish Rite. So again, a lot of our precious 30 minutes are spent at another facility. And the majority of those patients come to us by ground transport, not air. Looking at elements that are already in place, first and foremost, I can't say enough about the Georgia Office of EMS and Trauma. Without Dr. O'Neill, Renee, and Marie's leadership and gathering of the data that exist in the trauma registry, a lot of the information that you have already had presented to you would not be collated or collected or known to anyone except those of us in the Georgia Committee for Trauma Excellence. This is composed of the trauma coordinators and the trauma registrars throughout the state. Many times we've been the only voice in existence for trauma care in Georgia for over 14 to 15 years, and now we have the state office that is also joining us, as well as your subcommittee to help us develop and maintain a trauma system in Georgia. Another element that's already in place that many of you may not be aware of is the diversion website that is already on the internet, easily accessed by any EMS or hospital personnel that will tell you which facilities are on diversion, how long that diversion is expected to last, and the reason that diversion is in place. You've heard alluded to many places that go on diversion because they just don't want to deal with whatever. There are valid reasons to go on diversion. Those of us that are designated trauma centers utilize, we don't have an operating room available, we don't have a CT scanner available, we don't have a surgeon available to take care of that patient at that point in time. But that website has been up and running since around 2001. Many people do track the diversion hours and the reason they are on diversion, and I can tell you that at Children's Healthcare of Atlanta, that is something that we are particularly dedicated to look at, because we know that we are one of the few places in the state that children can go to when they're injured. Two other elements that are already in place: Children's Response, which is our transport team that can go anywhere in the state. We provide ground, air, rotary, and fixed wing transport to get children with whatever injury or medical need they may have to an appropriate facility for their care. And then we also have sponsored Safe Kids coalitions. There are 24 coalitions in the state of Georgia that look at injury prevention. What sort of trends are we seeing in our pediatric population, and what sort of interventions can we put in place to protect the children? Child restraint laws, proper installation of car safety devices, helmets, looking at ATV accidents and other accidents that come in to play in the pediatric population, and what education or intervention or even sponsoring of legislation can we provide to protect our children. As far as recommendations for accountability mechanisms, you already know we need funding, but we would want that funding to be allocated to qualified trauma centers. And by qualified, we would mean those centers that are either ACS verified or designated by the state of Georgia. And that should be voluntary participation. Not everyone who calls themselves a trauma center or who thinks they get the patients are going to meet the criteria or have the resources available to them. And I don't think it should be mandated, but yet a voluntary thing that, yes, we do want to participate in this. We do want to provide a high level of care, and we do want to meet the requirements as put forth by the state, which, in case you didn't know, the state uses the ACS verification criteria for state designation. Another component of the accountability mechanism would be an application for reimbursement. This could be quarterly versus annually. Again, the more frequently the application is met, the more administrative costs would be involved. And the application should be in, just as we do for our trauma registry. Number one, start with the ICD-9 code range for injury, with the exclusions of some of the minor things such as abrasions, contusions, those things that we already exclude from our trauma registry, plus one of the following. So in other words, they've got to have the injury, then they would also be involved in some level of trauma team activation, be admitted to the hospital or facility for greater than or equal to 48 hours, be transferred into a facility, which again 66% of our pediatric patients are transferred into Children's Healthcare of Atlanta, or be some either DOA, died in the emergency room, or died at some point in the hospital. The distribution of funding should be based on the volume of trauma patients seen at the facility, as well as their level of designation, the severity of injuries being seen at that facility, and any accountability or non-reimbursed charges. With that said, I'd like to take the opportunity to give you a brief case study on what happens to a pediatric patient. This is an actual case that did happen in the metropolitan Atlanta area, and give you an idea of why this is important, not only for our trauma system, but particularly for our children in Georgia. I'm going to tell you about a 2-month-old child that was involved in a car crash in metropolitan Atlanta. The child was restrained in a car seat, however the car seat was not properly installed into the vehicle. The child was ejected in the car seat from the vehicle, and as is so typical, when a parent and a child are involved, they were both put in the same ambulance and taken to the same facility. At that point, the child was crying, inactive, and according to the EMS providers, looked okay. Remember that children have a platinum 30 minutes for appropriate intervention to occur. The clock has started. Let's proceed. The child arrived at the non-trauma center in metropolitan Atlanta, and at that point was noted to be gone from crying inactive to being only responsive to pain. Evaluation of the child's injuries proceeded. A CT scan was obtained. It showed a skull fracture. And from this point, the child began to deteriorate. There was breathing difficulties. A breathing tube was placed. And at that point, a call was made to a pediatric trauma center to transport this 2-month-old child. Prior to the transport occurring, they discovered that the breathing tube was not in the trachea, it was in the esophagus, so the breathing tube that they thought was in place in providing air and oxygen for the child had become dislodged. They removed it and replaced it, and transport to the Pediatric Trauma Center began. On arrival at the Pediatric Trauma Center, initial Glasgow Coma score, trauma scores, and pediatric trauma scores, as you can see, are all bare minimum. They're at the lowest level that they could be for a child. Resuscitation began in the emergency department. The child was stabilized and admitted to the intensive care unit. Fluid resuscitation began with a massive amount of blood products, a lot of medications to support the blood pressure. Other adjunct life-sustaining measures were taken. And at this point, it was noticed that the child's head circumference was increasing, indicating that there was a bleed within the scalp, not within the head, but within the scalp. The child still had spontaneous respirations and still responded to pain. As time went on, the intensive care unit, heart rate decreased, medications were maxed out, and the child was pronounced dead later that morning. The child had arrived at the Pediatric Trauma Center at 11:30 at night, spent 80 minutes in the Pediatric Trauma Center ED, and 3.5 hours after arrival at the Pediatric Trauma Center was pronounced dead. 6 hours, total of 9 hours post-injury, 6 hours were spent at a non-trauma center. On autopsy, it was found that the child's cause of death was a bleed into the scalp. Had the child arrived to a pediatric trauma center or an adult level 1 trauma center with pediatric commitment within that 30 minutes, or certainly within the first few hours post-injury, that injury was survivable. Children are fragile but resilient. If taken to an appropriate trauma center post-injury, they can not only survive their injuries, but go on to have full and productive lives. Thank you for your time, and I'll entertain any questions.
Thank you very much. Any questions for Ms. Koskowski?
Jack, I know that 30 minutes would be the ideal time for children, but 30 minutes goes so quick. We just had an accident in my hometown of Cairo 2 weeks ago with a grandmother who's one of my neighbors, was driving, taking her two little grandkids to school, and she turned in front of the log truck, and her daughter got killed, and the two little kids were terrible, 5 and 8 year old. They were transported over to Thomasville, and one of them air flighted to Atlanta with just terrible fractures in the face and so forth. But they couldn't get them in 30 minutes. So what percentage do you think of your kids really get to a trauma center within 30 minutes?
To a trauma center within 30 minutes, less than 2%.
That's what I thought.
Thank you so much. We appreciate your testimony. I would be very grateful if we could get a copy of your presentation.
We have those.
Thank you very much.
Our final presenter prior to breaking for lunch is Dr. Jeffrey Nicholas from Emory.
Good morning, early afternoon. It's a pleasure to be here, and I thank you for the opportunity to speak to you today. I'm going to speak to you from the perspective of a surgeon that takes care of these patients on a daily basis, and as you heard from Dr. Haley, I work at Grady along in close conjunction with Dr. Haley and his colleagues, and we see over 4,000 trauma activations per year. About 2,500 of those translate into admissions for over 24 hours. Those numbers include about 350 burn admissions and about 650 or so patients which are admitted, observed, and discharged within a 24-hour period or discharged without need for admission. If you just do some simple math, you can figure out pretty readily that that works out to about 10 or more of these activations a day, roughly one every other hour. So this is not something that occurs intermittently. This is an ongoing round-the-clock problem that we see. And those of us who deal with it regularly have come to realize that it's a disease of nocturnal disease of weekends and holidays, unfortunately. But those times are the busiest, and those are frequently when the resources are at the minimal. I guess we're asked to try to address 3 questions today. Most of you know what these are from previous speakers, and so I'm going to go into what elements are necessary to support and sustain a trauma system within the state. I think a big thing is public awareness. I think this is an under-recognized problem. I think none of us like to think about this, but trauma is the leading cause of death in patients between the ages of 1 and 44. It's the most productive members of our society. It's our taxpayers. It's our family breadwinners. And 80% of these deaths are in the 15 to 24-year-old range, and it accounts for 60% of childhood deaths. So this is not an insignificant problem, but it's one we don't really want to think about. Everybody knows you get heart disease if you live long enough. Everyone knows someone who has cancer if you live long enough. But nobody wants to think about sustaining a traumatic injury in the most productive years of your life. But trauma exceeds causes of death from cancer and cardiovascular disease up until the 5th decade. Those of us who practice trauma know that there's a golden hour to resuscitate patients. And you can see here, this is a classic paper that kind of produced this data. And it's old data, but probably holds fairly true now. But the majority of these deaths occur either at the scene or within hours, certainly within 24 hours of admission, or about 80% of the deaths. These are the ones we consider potentially preventable. And so the American College of Surgeons and the Committee on Trauma has used this concept of the golden hour to emphasize the importance of getting a patient to the right facility at the right time where they can get access to expert trauma care during a period of reversible shock. Well, what makes trauma centers different from any other acute care facility? They guarantee immediate availability of specialized surgeons, nurses, emergency medicine personnel, anesthesia, and resuscitative life support that's available 24/7, 365 now. It's not calling someone in from the outside. It's not assembling an operating room that's available. These facilities have the capability to take care of these patients upon arrival. Fortunately, the majority of folks that are injured will not need that level of care, and this just kind of illustrates that the majority of people injured will sustain rather minor injuries, and as you go up a spectrum of severity of injury, they fewer and fewer patients, as you might expect. And hence a tiered system is very useful to care for these patients, and when you get out into this area out here, this is where the level 1 systems really come into place, tertiary referral for really a minority of the injured trauma patient. So a tiered trauma system is essential if we're going to proceed with this in the state, and we have that existing today. But just to kind of refresh you all on what that is, level 4 is essentially somebody can initially respond and stabilize someone. They produce and basically take care of the ABCs, or the advanced trauma life support. Level 3, basically similar type things, a little more advanced, but both of these centers will require transfer agreements for complex injured patients to either level 1 or level 2 facilities. They're not going to be equipped to take care of the small percentage of these patients with the most complex problems. Level 2s and level 1s should clinically be able to accomplish similar things. There's really very little difference in terms of what you should be able to accomplish from a clinical perspective, but a level 1 is certainly a regional resource. It's a tertiary care referral center. It's a lead hospital central to the network, and it generally has requirements for either graduate education or some type of research out of the institutions. This is our distribution of trauma centers within the state. I'm sure most of you have seen this, and of course the concerning part of our state is in the southeast region here, where there's just poor access to trauma centers. I spent some time in Florida, and just to kind of compare for you, the trauma centers in Florida are scattered as well. And if you pair our state with Florida, what really gets scary is as you go south and you drive through Florida, the disparate area of trauma care in Florida is in the northern part of the state, and it's really not bounded by a state border, but there is a long gap as you go from south of Macon into essentially Tampa area. The difference with Florida from our state is this is all regionalized in the state of Florida, and it's divided into zones, and if you're injured in one of those zones, you will go to a dedicated trauma center, hopefully from the field. Well, that's all well and good, but this is some of the data from our center. This is Grady Level 1. This is transfer requests. These are not people that are brought from the field, but these are calls from another center trying to get people into our center. And we had about 430 of these from 44 different institutions in the last year, and you can see here that we were able to accept 240 of these, and of note is the majority of these are not from in-county. They're from outside of Fulton and DeKalb area. A few from out of the state, one from out of the country. That's when the system works. This is when the system doesn't, and this is kind of where we're at. We had to turn down 190 of these requests, majority of them because no beds were available, no ICU beds available, or we were on trauma or ECC diversion. Occasionally an MD for the requested specialty unavailable. That doesn't happen so much at our institution, but it's a big problem with orthopedic and neurosurgical care at some of the other less designated centers throughout the state. As you know, and you've all seen this, and these are probably not up to date, but we're reportedly behind the national average in terms of trauma deaths. And if we just met the national average, about 600 lives could be saved in the state per year. And although we see a majority of 32,000 traumas, only 13,000 of these are actually getting taken care of at the designated trauma centers within the state. We have good EMS response time, we have reasonable transport times, but we have fair length of time to definitive care, and a lot of that is because these people can't get transferred to an appropriate facility because there aren't beds available, there's trauma center diversion, and rural access, I think, remains a concern within this state. You've heard earlier about the uncompensated care, and this is obviously low based on a talk or at the onset of the second session here. I guess upwards of about $210 million now, and of course Grady absorbs a significant amount of that. We have problems with diversion because, as you've heard, overcrowded ICUs, the anesthesia post-care units are backed up, the emergency departments are backed up. It's not all through the front door, though. We have real problems with the back door. We can't get people out of the hospital. They're unfunded. They don't have resources to go to rehab centers, and we can't get people out of the hospital as well. So the lack of getting out to a rehab center equally compromises the access to care as much as what's coming through the door. And we have absolutely no surge capacity. Well, this is a comprehensive system. This is taken from the American College of Surgeons gold book that they put out on trauma. We have pretty good things that you see in the center of this graph here. We have good pre-hospital care. We have designated and dedicated trauma centers. And we have good acute care facilities that handle a lot of our trauma within the state. We do have leadership. We have good leadership. We have system development in its infancy, but we really lack the finances and the legislative mandates to be able to move forward with a comprehensive trauma care system for the state. So in summary, we have good leadership organization, the State Office of the EMS. They're able to oversee this entire system, I believe. We have good prevention programs, although not enough. But despite the best, there's going to be people that are injured. And when those are injured, we have dedicated trauma centers with adequate resources being the key. The trauma centers exist. I'm not sure that the resources do. We have regional access to the trauma centers with good pre-hospital care. We lack transfer agreements amongst those centers that would really coordinate this in a timely fashion. We need a good network of rehab centers, sustained funding and finance, and legislative as well as public support. But what elements are in place of all those things we need? This is a document put out by the American College of Surgeons. This is the optimal resource document for trauma management. This is the gold book, as we call it. It's what the American College of Surgeons uses to verify trauma centers. It's what our state uses to go around and verify the existing trauma centers. And that's been ongoing, and re-verification is in process. And we have many of these centers within the state that teach the Adult Trauma Life Support Program, which is basic resuscitation for all hospitals and providers. We have good trauma centers. These are the places, as I said, that have all the right stuff available immediately for the patient, not upon request for people to come into the hospital, but immediately 24/7, 365. And we have 4 level 1 trauma centers that have all the right stuff. They have good leadership, good resources, they're teaching institutes. They have great educational programs, and research comes out of all 4 of these centers within the state. The Georgia State Trauma System Development Committee has come out of the State Office of the EMS, and this is a group of people which have put a lot of time into trying to develop a system. There's been a lot of groundwork already laid for this. I think it makes sense to continue with the work that's already been done, and this has been great efforts by the State Office for EMS. There were 6 subcommittees in here, and they laid out a plan basically to provide a safe and secure environment with a focus on preventing injuries when possible, and when that fails, to provide optimal care for injuries that have occurred. Similar type mission statement, and again, you can see that there's a plan laid out here. These folks have put a lot of thought into this. What have they done? Well, all the designated trauma centers in the state have been reviewed and re-verified, I think going back to 2001. They're in compliance with the state requirements, and part of that compliance is submission of a data set to the state registry. So there is good data available, at least from the trauma centers. And these places undergo redesignation by the State Office of EMS to ensure that they continue to remain in compliance with what we would consider appropriate trauma care. There's aggregate trauma center data that's now been collected by the state. This has been submitted by all the trauma centers that currently exist through the TRACK system, which is the Trauma Registry of the American College of Surgeons. There's a medical oversight or review committee that has the ability to sort through this data. And all this data is available for study to help guide some of the problems that come out and that can be identified within the state. There's plenty of internal monitoring for a system. There's a verification process, which I've already spoken to you, that the state performs. There's a statewide aggregate database and a state medical review board. And then each of the individual trauma centers undergo a rigorous self-inspection, if you will, of their own outcomes. And all of us maintain a trauma registry. At Grady, we have a trauma outcomes review committee that reviews all traumatic deaths. And as well, we have weekly M&M conferences which review morbidity and mortality from all patients that are taken care of. So in summary, the lead state organization I think exists, that being the State Office of the EMS. We have dedicated hospitals. We have lead level 1 institutions. We have good internal and external oversight and review that's already in place and probably just needs expanded. There's aggregate data to move forward. There's legislative interest and support, which I'm very glad to see. And I believe there's increasing public awareness, but a lot more that's needed. How about accountability mechanisms? I think I've already addressed this, but I think the state is probably, the Office of EMS probably provides the lead for accountability. The dedicated trauma centers by maintaining their verification status and as well reviewing their own complications and morbidity. The American College of Surgeons as well has a group that's available to go out and review state systems that are set up, and we could invite an external review by a national organization to come out and review the system that's set up in the state and actually assist with that process. And I think one of the great measures of the success of this will be our ability to absorb and increase surge capacity. So that's all I have. I appreciate the opportunity to talk to you and briefly address any questions.
No questions. Thank you very much.
We don't have any questions. Thank you very much. Chairman Statement going to speak to us about the schedule of the balance of this meeting.
Thank you. We're going to take a 1-hour break for lunch and a tour for some of the members of the committee. So we will reconvene in this room at 1:35. 1:35, we have 5 more presenters. We are going to conclude this meeting by 3 o'clock this afternoon at the very latest because of the schedules of committee members. So please be in the room and ready to reconvene in exactly 1 hour. And if I could ask the committee members to please follow Amy and do not disperse, but if at all possible, follow her now for lunch and what we're going to be doing for the next 1 hour. Thank you.
And there's lunch available in the back?
Lunch in the back for everyone in the room. So. I believe we have 4 people who are waiting to give testimony this afternoon, and so we're going to try to do those as quickly as we can, and no later than 1 hour from now, we need to be pretty well wrapping this up. So if our presenters would keep that in mind, I would be very grateful. We're going to begin this afternoon with Mr. Courtney Terwilliger, if I said that correctly or close, who is with the Georgia Association of EMS. We welcome you and appreciate your coming to give testimony this afternoon.
Good afternoon, and thank you for giving me the opportunity to speak. I'm Courtney Terwilliger. I'm the chairman of the board of directors for the Georgia Association of Emergency Medical Services. Also chair the Department of Human Resources Emergency Medical Services Advisory Council. So I wear a couple of hats in that particular area. I've been an EMS director in Emmanuel County, Swainsboro, Georgia for a long time. Been in EMS for 30 years as of last month, so I sometimes feel my age. A couple of different things. Who we are. We like to think of ourselves as a critical link. What Georgia Association of EMS does is 5 conferences and one other event. Those that are in red, Changes Conference we do every year in Augusta, Georgia. EMS conferences here on the coast. Management Conference we do at Unicoi. Educators Conference we did last week over at Pine Mountain. State EMS Award Banquet every year in Macon. The legislative reception is the one that we've always done. The other conferences that are in red started off as state functions. The state government started those conferences, and over the years, as funding dwindled for EMS services and EMS systems, they had to get out of those businesses, and we ended up taking those things over. Who EMS is, 1 call every 33 seconds, 1.8 calls every minute. Essentially, this is 2005 data, 930,000 calls in 2005. We feel comfortable that we're pretty close to the 1 million ambulance calls in the state of Georgia every year. So we reach out and touch a lot of people every day. I consider it the critical link in trauma systems for this particular slide. 89% of what you do, we bring to you. So 73% of it comes by ground ambulance and 16% of it comes via air or helicopter, and we feel very comfortable that you could not do your work without our work. And quite frankly, you will not succeed unless we can succeed also. In the system, for it to succeed, we all have to be able to do our part, and we hope to be able to continue to do an excellent job at that. over 13,000 licensed professionals. Got another slide in just a few minutes for me to tell you that I'm a little concerned about that number now. Resources, 282 plus or minus licensed ambulance services. And you find in Atlanta they come and go a little bit. We have some debate about the number of helicopter services in Georgia. Some of them say 5, some say 6. They are not regulated at this point, but I will point out to you that the helicopter services in the state of Georgia, we have been extraordinarily fortunate to have the quality of performance that we have out of our air services. Processes, the things that we think we need: training, licensure, medical directors, direction, standard medical protocols, and I'm going to tell you a few things in a few minutes about some goals that we would like to see out of the trauma system. Number of calls received monthly. If you notice that one little spike there, anybody know where that's at? Yes, Atlanta, Georgia, Region 3 is an interesting dynamic in the state of Georgia. And if you look at that and kind of cement that slide in your mind, there's a couple more that'll come in. You'll see that it changes a little bit by the region. Ground ambulances by region. Again, if you'll notice, Atlanta has quite a few ground ambulances. And as you go across the rest of the state from the different regions, you will find that some of the regions, particularly those rural regions, do not have anywhere near as many ambulances. Now, if you look at licensed ambulances per 100 square miles, then again you find the rural areas more sparsely populated have a great deal less ambulances to provide that care. And as we talk about regionalization of services, trauma services, stroke services, cardiac services, that slide there is crucial for you to understand what our problems are. The critical link, again, these are the helicopter services, and the circles there are 10-minute out. These services cover a great deal more distance than what is indicated there, but at the same time, I'll point out what you already know, that there's a certain part of our state that has huge issues. State labor shortage, wonderful slide. And the State Office of EMS, who has been very supportive of us 2 years ago at the request of our association and at the request of MSAC, set out and surveyed the EMS directors in the state of Georgia because we perceived something they did not. We perceived a distinct shortage of the people who do what we do. Okay, 100% of the individual owners that they surveyed said we had a shortage. 56% of surveyors had one or more paramedic openings, 8.2 cardiac technician, 34% who were surveyed have EMT intermediate jobs opening, 5.7 EMT B, and 89.3 indicated a statewide labor shortage. All types of providers affected all over the state of Georgia. And I'm here to tell you that was 2 years ago and has not changed except gotten perhaps a bit more critical. This I got from and I'm sorry Dr. Joe Robinson's not here, and he made one statement I'm going to repeat in just a minute. This data here came out of the Journal of Emergency Medical Services, a nationwide journal that deals with EMS issues. The researchers were from the National Register of EMTs, and I essentially put this into a slide, and it shows EMS providers per 10,000 population. Now, the survey went nationwide. I just took the southeastern regional states and looked at us in comparison to our neighbors around us and how many medics we have per 10,000 population. On this particular graphic, we're dead last. On this particular graphic, and to repeat, Dr. Robertson, thank God for Mississippi, we're no longer dead last, okay? But we're close. And that explains, hopefully will explain to you the critical nature that we have in our industry trying to meet the needs of Georgia. And I've had pages today in situations in my community trying to meet the needs of our citizens. Why do we have a shortage? Well, because not too many people want to do what we want to do. It's not the most glamorous profession. We're not Gage and DeSoto. Those guys went away a long time ago. Whole different TV shows now. But essentially the pay rate for the EMT intermediate is not a particularly lucrative field. You don't have a house on the coast with this kind of pay rates. So we're interested eventually in having folks look at that and try to help us meet some needs of our medics. This is the dirty little secret of EMS. All right? This is the dirty little secret. This came out of that same survey, and this was a survey of EMS directors. When asked of EMS directors, how many hours do your medics work? This is how many they worked in the different regions. Who they haven't asked yet, and who is the next group to be queried, is the EMS provider, the medics themselves. Because what you're going to find in my shop, 2/3 of my people work not only for me, but for another EMS agency. About 25% of my people work 2 full-time EMS jobs. And what does that mean? It means they'll come to work with me for a 24-hour shift. They'll get up at 7 o'clock in the morning, change uniforms, and go work for someone else for another 24-hour shift. My association sent me this past year to Washington, D.C. to the National Transportation Safety Board for their fatigue class. And it scares me what we're doing to our medics and the risk that we put the general public at, the number of hours our people are working. On 12/20/05, there were 13,927 EMS personnel in the state. That came out of a survey, a nice blue book that the State Office of EMS prepared. On 9/1/06, 13,186 total EMS personnel. What does that mean? In 1 year's time, we lost 741 EMS personnel. In 1 year, that's a 5% drop. Now, you have to understand at that same time, we are first-time testers are probably about 1,200 per year. So even with that, we dropped 741 people in 1 year. It is getting a little interesting. There's no, why don't people get into it? One, the pay's bad. There's no consistent retirement system in place for EMS. Some days we're considered public safety. Some days we're considered public health. The public safety people have retirement plans. The fire and law enforcement, the public health have retirement plans. Many EMS people do have retirement plans. Hospital-based have them, some county-based have them, but they're almost always based on retiring when you're 65 years of age. I'm not 65, I may look it, but I can assure you I could probably be an EMS director behind a desk until I'm 65. But my medics cannot run ambulance calls until they're 65 years of age. So what we've got is people who get 50, 55 years of age who were physically wore out. And my tongue-in-cheek comment is we do have a retirement plan. It's called workman's compensation. That's not a good way to do it, but it's the way we're doing it a lot of places. So we're looking to help develop a retirement plan for our people. Most EMS people injured in the line of duty must survive on workman's compensation. State money budgeted at the Georgia Public Safety Training Center. Dale Mann's a wonderful fellow. He runs a first-class operation. We talked with him last year. We found out this. He's got $0 budgeted for EMS education. He would like to help, and last year the legislature was kind enough to change the law so that he could help. State money budgeted for the State Office of EMS for training, $0. They do have training coordinators out there, and they do some excellent work with us, but they have no monies there. And one of the things that I fear is that State Office of EMS, most of their budget comes from the block grants that come down from federal government. And every year we fight to keep that block grant funding there. And every year we're afraid if that money goes away, what happens to that State Office of EMS that has supported the trauma system and the EMS system? And we're a little concerned about that. Federal Homeland Security money provided for EMS less than 4%. So we struggle dealing with not a whole lot of finances. The regionalization of EMS, what we're seeing is trauma, rightly so. Rightly so. I work for Emmanuel Medical Center. We will never be a level 1 trauma center. Okay? We will never be a level 2 trauma center. And one day we might be a level 3. But the bottom line is we will never do that. So what we need to do is be able to have a transportation system to get people from Emmanuel County to Savannah or to Augusta or to Macon. You're seeing the same thing with the folks who are working with strokes. They want the exact same thing to the certified stroke centers. You're seeing the same thing with the cardiac people in the Seaport study being done in South Georgia. What does that mean for us? Transport times. Average call in Emmanuel County, if I pick somebody up, take them to the hospital, I'm going to spend 35, 40 minutes on that call from start to finish. If I take someone to the trauma center, I'm going to look at 4 to 5 hours that my unit is tied up. That's a unit out of my county that can't do primary 911 type calls, but it's essential that we be able to do that. Available resources, so many ambulances available. If you go through South Georgia, and there was that slide a few minutes ago and talked about in Region 6, there's 1.5 ambulances per 100 square miles. Okay, that's how many licensed ambulances. I have 4 licensed ambulances. At the best time of the day, I staff 2. Okay, so if I take my available resources out of my county to do what I need to do for my citizens, for my friends, for my family, it stretches my resources thin on a given day. ED wait times, and we have been fortunate with that. There are places in the state of Georgia that you may take a patient to be offloaded and spend 2 hours in the emergency department. It's not because they're bad people. They don't have a bed to put them in. Okay, one doctor said they don't have a back door. They have a hard time getting patients out. And indeed, years ago, almost all of our transfers were early in the morning, 10 o'clock. Now almost all of our transfers are after 5 o'clock. Has nothing to do with what we would want to do. It has to do with what I call the hotel system in hospitals. They have to get patients out before they can get patients in, and they can't take our patients in until they get those patients out. Patient care versus budget, we call helicopters. And quite frankly, we've been very aggressive about calling helicopters in our service for a lot of years. Every time I call a helicopter to take one of our patients from Emmanuel County, the idea is to save that life. to get them where they need to be. But the other little side of that is every time I do that, it costs my budget $1,215, because that's what I would have billed for that transport. For me, that was $62,000 last year. That's a difficult conversation to have with the county commission, but that's the reality of what we do. What do we do? What do we need to do? We need more people. We need to ensure an adequate workforce for what we do. We need to increase training. We need to make sure that more EMS personnel are there. Our training needs to be focused on trauma. If you talk to Fred Grant, who is an extraordinarily smart fellow, works for the State Office of EMS, he will tell you that one of the reasons that EMT students fail their boards is because they're not well-rounded in trauma. So we need to do that. Develop a mobile retirement system for all 911 providers. We need to include the EMS in the public safety disability planning. We need to ensure adequate funding for EMS. One of the surveys I'd like to see the state do is I'd like to see how many ambulances are out there and what's the mileage on the odometer. I was in a county close to mine a few weeks ago in another meeting, and I walked up to their first line out ambulance at 157,000 miles on it. And I'd love to point my finger at them, but that's not far from where mine are. Okay? That's a lot of miles for an emergency vehicle for your primary care vehicle. It needs to be based on patient needs. We need to ensure adequate personnel training and equipment in all the regions of Georgia. All Georgia citizens, whether they live in the big city or the rural areas, need to have access to adequate trauma care, excellent trauma care. Processes: encourage the State Office of EMS to continue to assist the EMS community in training and standards development and make sure that they remain clear in this vision. And I do brag on Dr. O'Neill. He has done a very great job in what he does. And he's kind of the champion for EMS the way he is a champion for trauma. He spends a tremendous amount of his personal time doing that. Encourage all technical schools to participate in EMS training. They don't all do that. It's up to the technical school, the individual school, whether they do that training. And we have been great partners with them. They provide Hope Grant training for EMS education. Georgia is one of the few states in the nation where EMS people can go get training that way. Processes: ensure the development of specialized EMS training at the Georgia Public Safety Training Center. Our people, when you see them coming down the road going fast with lights and sirens on, understand that there is no training in Georgia to provide training for those folks to drive that vehicle other than classroom training. Okay? We used to have that, and it went away. We'd like to get that back. Ensure that EMS is involved in all local, state, and federal disaster planning. And that sounds like a gimme, but folks, it's not happening. It really is not happening. Wish it was. Ultimately, it's about taking care of people. Thank you, gentlemen.
Thank you very much. Any questions? We appreciate your testimony. If you can make sure we get a copy of your presentation, we'd very much like to have that for our record. Thank you so much. Appreciate it, Courtney.
Our next scheduled presenter is Gary Nelson, PhD, President of Healthcare Georgia Foundation. Is Gary Nelson in the house? Apparently not. We will go to Wayne Reese.
Mr. Chairman, I've asked to be deferred for the next meeting.
Dr. Doug Skelton, Director of Public Health, Coastal Health District.
Senator Staten, Representative Chanel, members of the committee. I only have a few comments to make, but I want to thank you for your efforts to deal with a serious problem in our state. I'm here for several reasons. I've listened to all the testimony, and you ought to be given continuing medical education credit because it's been outstanding. But it makes me wonder, when you're there in Atlanta, who do you look to talk to you about the health needs of this state? What's the lead person to? Where do you look to find the kind of information that you're hearing today about the kind of problems we're facing? I want you to think about that as I make just a few brief comments to you. I'm here, one, because years ago, as the Department of Human Resources Commissioner, I became interested in emergency medical services and trauma. So So I've seen it develop all the way from not having certified emergency doctors in the emergency rooms to where we are today, hopefully taking the next step to a statewide trauma system. I'm also here because I serve as the health director for the Public Health's Coastal Health District, 8 counties of Georgia. I wonder if all of you know in the General Assembly that all of our public health staff today are designated first responders for emergency preparedness and response. That is because of a federal designation. That means when they're recruited today as public health nurses, that doesn't mean they can work 8 hours a day, Monday to Friday. That means if, in case there's a disaster, an emergency, they are on 24/7 call. I guess you could say public health staff are now required to put themselves in harm's way because of a federal requirement. Public health in our state is the coordinating agency for Emergency Special Function 8, which is health and medical. The secondary agency for Emergency Special Function 6, which is taking care of mass casualties, shelters, special needs patients, getting them out of the area when hurricanes come. And trauma fits in this in a huge way on the health and medical part of Emergency Special Function 8, which ought to be organized in every county involving hospitals, involving public health, involving the EMS programs that were so eloquently discussed a moment ago, involving Red Cross, involving others to plan for how we're going to deal with major emergencies. Are there problems in this system? You bet there are. There are huge workforce issues in all health professions in Georgia, in all specialties in medicine, and there's some internal issues. You think it's not an internal issue when public health nurses are supposed to be first responders and supposed to be able to provide immunizations to everybody in their counties within 48 hours? That's the federal requirement. Everybody in the county within 48 hours. I can't get enough public health nurses in Bryan County to keep the clinical services open 5 days a week. And part of the reason I can't get that is because some of my fine hospital colleagues can pay nurses $20,000 to $25,000 a year more annual salary than the state allows them to be paid in the public health program. And it's even worse for licensed practical nurses as to what they can get paid. So here we have the federal government solving their problem about the next emergency by saying to the state of Georgia, you've got to be able in pandemic flu to immunize everybody in every county in Georgia within 48 hours using your public health nurses to do that. There is no way. So when that doesn't happen, who are they going to blame for it didn't work out? We didn't do it. It was a federal requirement. We weren't able to do it. So those are some of the issues that we face. Medical education was mentioned. Many of you know me. I've had a career committed to that. I'd like to see more education across all health professions. We started out in Georgia with some of the support for several of our medical schools targeted at certain specialties. That was a quarter century ago. We need people in primary care. We need people in all the specialties. We need to quit worrying so much about recruiting everybody that's a Georgia resident. A lot of these good kids would come here from other parts of the country, get educated, and will stay here and practice. In fact, you ask the physicians that testified here today, many of them came from other states, trained here, then settled here, help us meet our problems. Let me close by commenting on something somebody else said. Emergency care is highly fragmented. I agree with that. But from my view, the state's health activities are highly fragmented. And out of that fragmentation has come a loss of $10 million in public health funding over the last 5 years. No effort to pick up $3 million in lost federal emergency preparedness money. You would think if our federal government is helping us build the capacity to take care of our systems our citizens when they're challenged with a hurricane, that we as a state would at least try to pick up some of that money when the Fed pulls it back. As far as I know, nobody even brought that to your attention or asked you to think about it, because I believe if they had, you would have thought about it. So I wonder, where do you look when you look for health leadership in the state? I know where you look when you look for transportation. I know when you look for some other places. And I used to head the Department of Human Resources before that term meant a personnel agency. I wonder today, are you getting the messages you need to get about the health care needs of our state? Thank you for the opportunity. Be glad to answer any questions.
No questions.
Thank you.
Thank you, Dr. Skelton.
Thank you very much, Dr. Skelton, for your testimony. We're now going to hear from Christopher, is it Schleicher?
Exactly.
Very good. Getting better at this. We welcome you and your testimony.
My name is Christopher Schleicher. I'm an attorney in Atlanta, and I have been working in the ambulance industry for a number of years and represented a number of different companies in all kinds of matters, regulatory matters, 911 ambulance zoning matters, reimbursement matters, legislative matters. And I've been the principal attorney for Rural Metro Ambulance here in Georgia for about 8 years. Mr. James is going to be here with me today, but I think he's still in the security line at Hartsfield right now. So I want to just tell you quickly a little bit about who Rural Metro is. Very big company. We handle about 60,000 emergency calls in Georgia each year. We're in 22 states. We employ about 350 people here in the state of Georgia. Generally, I want to focus a little bit on diversion, the issues that raises for an ambulance company in the street, and then talk about very quickly a couple of solutions that seem workable from our point of view, or that at least seem necessary. The key elements that we think would be necessary at the field level where we work on the street would be public education, regional coordination of resources, and prioritization of patients. As far as which of these elements are currently in the system, none of them are. The ambulance providers, and our work is mainly in more urban settings, so it's a little different than what Courtney was describing to you. And we operate what are called system status management plans, which what happens is we have a number of ambulances based in a geographic region, and then as calls come in, the ambulances are constantly shifting to provide coverage so that you always minimize the distance between an available ambulance in any part of your territory or zone where you are. And so what happens when we have diversion problems, when we're not able to take patients to the closest hospital and we have to take them somewhere else, it screws up the entire system. It delays responses everywhere. It messes up the system status management plan. And so a time on task that should be maybe 45 minutes stretches over, well over an hour. And so when that ambulance goes out of the system, then you begin to have problems. If several hospitals in the Atlanta metro area go on diversion, which frequently happens, then you really have problems. We have nowhere to take patients. And one of the problems with the current system is that it leaves the decision making as to where a patient who is in critical need of emergency care, where that patient's going to go, the choice about the most appropriate destination is left to the least trained person. That's the That's the paramedic or EMT inside that ambulance. They're not the ones who should be making decisions about where am I going to take this patient. I can't take him to the closest hospital. Should I call an air ambulance? What should I do? Should I go ahead and just keep him and drive here? Should I do some Impala crashing, which for private providers, when the patient enters our ambulance, they are not yet covered by Impala. But we can go to a hospital that tells us they're on diversion, not taking patients, and once we get on a hospital parking lot, then they have duties under Impala to assess the patient. Well, that's a really bad way to run the system. I mean, it provides, it disrupts the relationships that we have with the hospitals and the providers. But on the other hand, what we have is our EMTs and paramedics are like the messengers stuck in the middle of the system, and they're sitting in the back of the ambulance negotiating with the hospitals and negotiating with the patient about where that patient is going to go. And what happens is the patient spends more time in the back of the ambulance than is necessary when they should be in a hospital somewhere. The things that we think that would help improve the stresses on the system that result from hospital diversion are, first of all, educating the public. There's no real funding for that currently, to educate the public about what hospitals provide what kind of care. A lot of times patients just insist on going to a certain hospital. They've been there before. They like it. They don't understand that only certain hospitals can provide certain kinds of care. They don't understand what diversion is and why they need to go somewhere else. And under Georgia law, in the end, the patient has the choice about where they go. So the lack of public education causes a lot of problems. The public also needs to, and I think everyone knows this, needs to be educated about the proper use of 911 and the emergency care system. We need to have some alternatives so that we can divert and triage calls away that don't belong in the trauma system, but that we have some place for those calls to go, and eventually that we have some place for those patients to go that's not in the trauma system. We need to, improving the 911 triage is part of that. There are many areas in Georgia that don't have accredited PSAPs, and so the people there who are doing the dispatching don't have the proper training, and this results in more inefficiency in the systems. Patients not going where they need to go, not going to the most appropriate hospitals, patients going into the system who don't need to be in the system. What we think that we need are regional medical control centers. And what I'm talking about here are physician-staffed centers, which could be hospital-based and a trauma center, but regional medical control centers that provide medical direction and coordination for an entire region. And so here then you would have not the EMTs and paramedics in the back of the ambulances, but qualified emergency physicians who would be deciding where patients would go, who would be monitoring which hospitals are on diversion, knowing where beds are available, what areas of specialty are unavailable in different hospitals, and that they would even be the ones negotiating with the hospitals about their decisions to go on and off diversion, not the EMTs and paramedics. What happens a lot of times out in the field is an EMT or paramedic will, as soon as they're dispatched on a call, someone will call the hospital and say, "Can you take this patient?" They'll say, "No, we're on diversion." And when it turns out the patient has limited options, the EMT or the paramedic will go off the radio system, pick up their cell phone, and call the hospital emergency room and ask for a charge nurse or ask for somebody that they happen to have a personal relationship with and say, "Can I please bring my patient?" And so if you're in the back of the ambulance, whether or not you get to an appropriate hospital in an appropriate amount of time may depend on who your EMT or paramedic happen to be dating that week. So we need to take all of that out of their hands and place it into a regional medical control center. And also that I've put down there document diversion history. As part of the public education, I think people need to know and understand about hospitals going on diversion and when they're going on diversion and why. I think most people will be very surprised to find out that the public hospital, the hospital near them, that they're not going to be able to get the care there that they think they're always going to be able to get 24 hours a day. They have no idea that it might not be available there or anywhere near them. And they need to understand that if they're going to support additional funding to enhance the trauma system. The other thing on there is in some EMS systems, and others may have already spoken to you about that, what hospitals do is coordinate and they share on-call physicians. And so in a given area, one hospital may be responsible for providing on-call orthopedic physicians for the emergency rooms during that time. And so they're sort of in a central area somewhere, but they can go to any of the hospitals, but it doesn't require each hospital to have their own orthopedic surgeon there 24 hours a day. And if there is a regional medical control center, then they can coordinate all that. It's difficult to do with just the hospitals between themselves if there are more than 2 hospitals. And this is an issue too that, and we certainly don't want to offend anyone here, but we've had, and other providers have had some really bad experiences, and where a hospital, and most people don't do this, and I don't think that, and I think this experience is certainly not with the level 1 trauma centers, but with other hospitals, and even with just acute care hospitals that are not designated trauma centers. What happens, they go on diversion. And we've had the experience where one of our medics or paramedics will convince somebody to allow them to bring the patient anyway, and the hospital's been on diversion for hours. And when they get there, the emergency room is empty. There are plenty of beds, but the problem is that the hospital beds, the beds for admitted patients, there are none available there. And in some hospitals, at least it's been our experience, that's because those beds are reserved for elective surgeries. And so it's not an issue of, it's not always, it is most times, but it's not always an issue of staffing the emergency room. Sometimes it may be a question about how a hospital chooses to use its resources. So we just think that trauma patients ought to have priority. And I think a part of making it more generally available when people go on diversion, when hospitals go on diversion, how often they go on diversion, and for what reasons. If there is some regional authority or center that's looking at those things and evaluating them, I think that this kind of problem will go away. And again, another one of the related issues is about ERs being overloaded, that the doors get closed to the ambulances before they get closed to the walk-in patients, who generally should be diverted somewhere else. And I think most of these things here that you have already heard about, and I don't have anything new to say there except about the last thing, about fast-tracking certificate of need process for freestanding emergency rooms. And we had hoped to have somebody here who operates what's called an emergency hospital. They do it in the Phoenix area, and they weren't able to be here, and they would be more than happy to come to one of your later meetings to talk about what they do. But essentially what it is, it's just a freestanding emergency room. And trauma patients go there, and if they may have surgery there, they're stabilized there. They stay there, though, for a relatively short period of time, and then after they're treated, and stabilized, and then there are decisions made about where is the most appropriate hospital for them to go, and so then they're transferred out. And this is a new way of thinking about how to handle trauma care. It's kind of a new paradigm about separating the trauma centers or emergency rooms from the hospitals, and allowing and having these freestanding facilities that their only function is to receive emergency patients. So that's all they do. They hire trauma physicians, and for this, when they need help in the specialties, they share those physicians from surrounding hospitals. But that model has been successful. I think they've tried it in about 6 different states, and it seems to be a very effective way to handle the problem. Just something to think about going forward. And that's just a summary of the things that we mentioned. Mainly for the EMS people in the field, what we need for the trauma system is we need management. We need centralized regional management. We need somebody who's going to help us know where to take the patient that's in the back of our ambulance. One thing that I did mention in those slides was about the use of air ambulance, and those air ambulance services are fine services, and in some sense they are our competitors. But there are many instances where a patient will be within 10 or 15 minutes of an appropriate hospital, but that hospital is on diversion for some reason, and so the patient ends up having to take a helicopter to, let's say, Grady from somewhere else in the Atlanta metro area. And what would have been a $500 to say $750 ambulance bill will be in the thousands, maybe $5,000, maybe more, depending on the severity of the patient's injuries. And that's an incredible amount of inefficiency to build into the system, and it's also not as safe. But that's one of the other problems that we have when we're close to hospitals. We can't take patients there. There's further delay. We have to wait for an air ambulance to come and transport the patient. So those are our concerns from the EMS perspective, and I think mainly what we would ask you to do is to support public education and to support regionalized medical control to coordinate the resources in the system and to coordinate what the different hospitals are doing to make sure that we have a place to take you when you end up in the back of our ambulance. Thank you.
Thank you very much. Questions?
Thank you, Mr. Chairman. Sir, can I ask you one quick question? You mentioned freestanding ER rooms, and you said they've been doing this in about 6 different states. ER rooms, for the most part, at least financially necessary evil. At least that's what all hospitals tell me. And everybody tells me they always lose money. Who would want to open a freestanding money-losing operation, and who pays for it?
Well, they have been successful, and they've been successful at doing that in Arizona. And I'm not sure whether or not they receive any level of state funding that's different than what other hospitals are getting. But it is a whole different cost structure when they're not supporting the entire facility that's in a medical center like this one. Then they're able to do it to handle the emergency room much more efficiently. Just a different cost structure, I think.
First, thank you for the presentation. You talked a little bit about diversion and described for the committee for purposes of us better understanding diversion and the consequences of diversion, and maybe even generally made some suggestions, but I'm wondering if you put any thought into what could be done legislatively by the people on this committee and our colleagues in the General Assembly to address the diversion issue.
We have some. As far as establishing the regional medical control, I think that's possible under the existing legislation. Title 31, Chapter 11 actually provides for regional zoning plans and the coordination of all these things. That's not what we really have. That's not how it's really worked out, but that's what the statute contemplates. So we don't really, when you read the statute, you would probably think that we have something close to that, but we don't. We really don't. We have smaller EMS zones. So it can be done there, I think, with some regulations to set up the rules for those things, that could be done without a legislative change. In terms of, and I don't have anything specific at this point, but in looking at the reasons why people go on diversion, I think the issue of priority of handling the patient and when you can and can't close an emergency room, I think that's something that we ought to look at about establishing some rules for that. But I don't have something specific for you today.
As a follow-up, why don't we have regulations that fulfill the intent of the statutes with regard to regional medical controls?
Well, that's a difficult question. There's a long history there. The system has sort of devolved down into a scheme where the state is carved up into 911 ambulance zones, and then in each of those zones there's a provider who manages those zones, and there are some areas that are designated as and I can't think of the right term right now. Courtney might know, but like base stations or something. There is some provision in the existing law for that kind of thing, but it just really hasn't happened. There isn't any, because when we're trying to take a patient somewhere, there's no single place that we can call. There is no real coordinating entity that's going to tell us you should go to this hospital or you should go to that hospital. We may have somebody, a supervisor, who's trying to check the websites and to see who's on diversion. Somebody else may be on the phone calling all the hospitals, and in the meantime, the ambulance is driving around trying to figure out where to go. I'm not sure why that has happened. But the system that we have now is much less, I think, than it could be under the existing law.
Mr. Chairman, another question really for Christopher, but I suppose for the two co-chairs. It seems to me that this issue of diversion is so central to providing immediate and even medium-term relief. And some of the other issues we're addressing are so structural and thus longer term in nature. It seems to me it'd be appropriate for us at one of our later meetings, or maybe even to invite this witness, because he has the benefit of a dozen or more, I think he said 22 jurisdictions, 22 states,
Right.
22 different states, to find a way to ask for some suggested, whether it be regulatory or statutory, changes so as to at least address this diversion issue. It seems to me that's something that can be fixed next year or in the next few years, where some of the other issues we're talking about are much longer term. I'd be interested to hear your response, and I've sort of volunteered you, I suppose, for some work. Don't let me do that if you can't. But I don't know if we have the opportunity over the next two meetings, the final two meetings, to take that issue on very directly and narrowly.
Thank you, Senator. It's certainly an issue that we've heard time and time again throughout our proceedings and as we've heard testimony. So I do think it should be on the list of the things that we are considering as we prepare our report to take back to both the House and the Senate. There may very well be some things that we can do more quickly there than in some of the other areas that we're concerned about. But I appreciate your concern, and we will certainly duly note it and see if we can have some more testimony on this issue between now and our final, or at one of the final two meetings. Any other questions? Thank you very much.
Thank you.
Let me just double check to see if Dr. Gary Nelson has returned to the room. We had understood he was here, but perhaps not. If not, then that concludes the testimony of those we have on our list who had requested to speak before the committee today. So we will very quickly conclude this third meeting of the Joint Comprehensive Trauma Services Study Committee. Let me say a word of thanks to our hosts here at Memorial Health University Medical Center. We appreciate very much the hospitality we've been shown, the tour, Amy, especially your hospitality last night for the Low Country Boil. This has been a very good meeting. I also want to thank the stakeholders. We knew that this would be a very important meeting, as we heard from people who are on the front lines on this very important issue that we are studying. And so we appreciate your input, your patience, your coming all this way to be a part of our meeting today. Let me say a brief word about our next meeting. It will be on November the 28th. That is a Tuesday, I believe, rather than a Monday, because we'll be coming off the Thanksgiving holiday weekend. We're going to be meeting in Thomasville. Our host will be the Archbold Medical Center there, a level 2 trauma center in an area of the state doing yeoman's work in an area of the state which is underserved. And so we look forward to that meeting. The theme of that particular meeting is going to be an opportunity for us to hear from experts in other states who are perhaps a bit further down the road than we are on this particular issue. So we have invitations out. We're in the process of putting together a list of individuals who will be giving testimony. If you have suggestions, if you have names of individuals or organizations, someone suggested this morning, I believe, that they knew many of the people in these states that are considered to be model states. We want to hear from you about that, because we are in the process of putting that meeting together. Unfortunately, there is this little thing called an election in a few weeks, which involves a few of us, and so we will not be meeting again until November the 28th, which is after the election. Any other questions or comments from members of the committee?
Mr. Chairman, on behalf of Chairman Larry O'Neill, go ahead, budget, sit again for today. I would also like to thank Bob Cobbin and Amy Hughes and all of the folks here at Memorial Health, and the staff for your great hospitality, and also for being a real asset to the state of Georgia, in particular this part of Georgia. You provide life-saving health care to a large number of people, and we at the state level appreciate it. I think it's important for those of us in the General Assembly to come out and see facilities such as yours firsthand. You know, during the session, of course, January, February, March, all of you all have to come trucking up to Atlanta, and although a number of members of this committee have spent a large part of 2 days and have traveled quite a distance to get here, and that's what we're supposed to do. That's why we get the big bucks, you know. But I also would like to thank the other folks here, the presenters and staff and other interested people for coming here and testifying for this committee. The work we are about is serious business, and it is my hope that we will come to some conclusions at the end of this process that will be beneficial to the citizens of Georgia.
Thank you very much, and on behalf of my co-chair, Representative Larry O'Neill, my thanks to Representative Chanel for his help today in co-chairing this event. If there's no other comments or questions, we will stand adjourned once again with our thanks to each and every one.
See you, lady. Pray I get back up there.